So over the next little while, we're going to run through all the different aspects of the urine sediment analysis. And some of my talk will follow on very nicely from some of the material that Dr. Renke covered, particularly towards the end of his talk, and we can expand on some of that information in a little bit more detail. So I have no disclosures. And here's the outline of what I plan to cover over the next little while. So we'll talk about, well, why do we do urine sediment analysis and what use is it really in this current day and age? I'll show you some data looking at the utility of really thinking about the number of renal tubular epithelial cells and granular casts on the urine sediment and how that can help us maybe risk stratifying AKI a little bit. I'll go through leukocyturia, some of the causes and how we can work that up. I'll spend a bit of time on hematuria and some of the syndromes associated with that. And then, because this is a board review and some of this stuff will come up in the boards, we'll talk briefly about lipiduria, and I'll show you some images and some examples of urine crystals that hopefully might trigger some memories and help you if these questions come up on the exam. Okay, so why do we do urine sediment analysis? And I love the title of this paper, a virtuous examination from a skillful and motivated physician. So this is why we do it. We want to be virtuous, skillful, and motivated nephrologists. But maybe something in a little bit more detail. And I think it's helpful if you think about the urine sediment analysis as a biomarker, because, you know, as nephrologists, we always complain that creatinine is a very poor biomarker of kidney function. The cardiologists have troponin. If we had something a bit more sensitive, we might be able to pick up kidney problems earlier. But the urine sediment can tell you nicely what's going on in the kidney, and it can give you some information about the compartment of injury. And with all this, I will add the caveats of its sensitivity and specificity, but I think when we see some abnormalities there, it can be helpful. What you see on the urine may change your treatment plan, so it's worth checking. And also it can be helpful when you're wondering whether someone's pre-renal or whether they're actually an established ATN and where the course of their AKI is going to go. And I'll show you some observational studies that suggest that greater degrees of renal injury on the sediment may correlate with need for renal replacement therapy. So if we think about urine sediment as a biomarker, and you look at what's being studied in the literature and, you know, tests that are being developed, and we go down the nephron, let's just get my pointer here. So when we think about the glomerulus, obviously we've got cystatin C, we've got creatinine, we look at proteinuria and albuminuria. But for glomerular injury in the urine, we would be looking for red cells and specifically acanthocytes in the urine or red cell casts, which are reasonably specific, if not terribly sensitive, but they are specific for glomerular injury. Once we get to tubular injury through the proximal tubule, the distal tubule, and the collecting duct, then we start to see renal tubular epithelial cells, or TEC casts and granular casts in the urine. And we obviously have this large number of other urinary biomarkers that are currently being studied and developed. And then the one thing that I think is worth remembering is that there are no current biomarkers for interstitial injury, and we do have white cells in the urine and white cell casts that can be indicative of an injury in the interstitium. So it's worth thinking about your urine sediment in that way. Mark Parazella obviously is a big believer in the urine sediment and has done a couple of nice studies about this I think are worth just looking at. So they developed a scoring system looking at urine microscopy and tried to assess its ability to predict worsening of AKI. So they looked at the presence of renal tubular epithelial cells, or TEC casts, and granular casts in the urine. And for this particular study, they formally trained a group of nephrologists to review the urine sediment, because I think skill and the eye of the person who's looking at this is obviously a critical factor when you're talking about urine sediment analysis. And then they got a second nephrologist who would do a chart review to figure out what they thought the diagnosis was and look at the correlation. So they took patients who had a clinical diagnosis of either ATN, that should be ATN rather than AKI, versus pre-renal. They had 197 patients, 134 of them had ATN, and 63 of them were pre-renal, and they had the full spectrum of AKI across stages 1 to 3 on the Akin staging system. And what were they looking for in the urine? These are the renal tubular epithelial cells that they were interested in, and these are the granular casts that we're all very familiar with. And they had a very simple scoring system where they had essentially a matrix where they put the number of renal tubular epithelial cells per high-powered field, 0, 1 to 5, or more than 6, against the number of granular casts per low-powered field, again, 0, 1 to 5, and 6. And what you're interested in are the group kind of down here that have higher numbers of either abnormality in their urine. And what they showed was that a baseline higher urine resediment score correlated nicely with higher akin stage of AKI. So, and they were able to use this to think about a risk ratio for those who actually were going to develop worsening AKI after the urine sediment. So I showed you the group that had the higher number of renal tubular epithelial cells or the higher number of granular casts. And if you had a score of greater than 3, where the scoring system went up to 4, you had a risk of 7.3 of worsening AKI on follow-up. So this is a nice correlation with outcomes subsequently. And then he published this later paper in 2015 that looked at a number of different studies that really had similar findings. And they looked at the AUC of their grading system in terms of predicting worsening renal function. And as you can see, if I can find my mouse, there it is, that worsening or higher numbers of renal tubular epithelial cells or granular casts in the urine had an AUC of about 0.7 in many of these studies. There's one here that's only 0.58, but had some predictive value in terms of trying to think about how your patient is going to do in subsequent follow-up. So one of the things that always comes up is that, well, you know, the urine sediment exam that we do versus what you see from the lab are different, and certainly skills and training between different nephrologists and experience is an important factor. But there actually are good reasons why when you look at the urine, you see something different to what the lab sees. And when people have looked at the nephrologist urine sediment exam, if I see the case and I examine the urine, it's thought to have a very strong correlation with the outcome, versus if I see the case and someone else looks at the urine, the correlation is not as strong in terms of accurate diagnosis. And whereas if I see the case and the lab looks at the urine, it's less than 25% correlation with an accurate diagnosis. And also we talked about the variability between different nephrologists. But when the lab examines the urine, their focus is much different to yours in terms of what they're looking to find. So the certification of the lab is based on accuracy in measuring number of red cells and number of white cells in the urine. So the volume that they reconstitute the pellet in, the duration of how they spin, and the speed at which they spin are all different to how nephrologists typically perform urine sediment analysis. And this explains why they are less likely to pick up casts than we are. They use a more dilute sample from the way we would examine the urine. So this was a paper from Scientific Reports in 2017, and I like this because it's unusual to find a really high-impact science paper that has something with urinalysis on it. But this was a group from South Korea who looked at the way nephrologists examine the urine sediment, how the lab examines the urine sediment, and then tried to merge the two together to improve the diagnostic utility of how lab sediments are examined. And this was an interesting picture from their paper. And as you can see, they give a large number of images of red blood cells. All these ones across the top are all isomorphic RBCs. And they rated all these ones in the lower panels here as all different forms of dysmorphic RBCs. Now, I think for most of us, the ones we would be interested in are these particular ones here, which are the acanthocytes. But for this study, they also identified that these were dysmorphic. So one of the things that they did, apart from looking at the suspension volume and the centrifuge speed, was that they used Sternheimer stain on the urine sediment to try to improve the ability to accurately identify the elements in the urine. And as you can see, when they looked at neutrophils, these were more easy to identify once they're stained. Squames are not too difficult. You can see the 2 nuclei in the urothelial cells nicely. But really to identify, say, white cells from renal tubular epithelial cells, the staining was particularly helpful. So this was something that they suggested that could be improved on the way that we currently look at urine to improve our diagnostic accuracy. Okay, so now that I've convinced you, you should look at the urine. Let's talk a little bit more about what's in it. So we'll focus on leukocytes initially. So what is leukocyturia? So it's more than 3 white cells per high-powered field on microscopy, and most of the time, as we know, it relates to infection. However, sterile pyuria is seen in about 14% of women and up to 3% of men, and your workup is going to be determined by what symptoms or renal dysfunction are present. What are the infection-related causes of sterile pyuria? It's a pretty long list, and we can run through. So those that are currently on antibiotics or have recently been treated for urinary tract infections, gynecological infections, so urethritis from either fastidious organisms or sexually transmitted diseases will not necessarily grow out, but you'll still see white cells in the urine. Prostatitis is one where you can get caught out if you don't have it on your list of differential diagnoses. Tuberculosis and parasitic infections can be important in the right clinical setting. And then obviously appendicitis, particularly where you have a pelvic appendix that may be abutting the bladder. You can get cystitis and white cells in the urine related to acute appendicitis. So the non-infection related causes are really trauma primarily to the bladder, but anywhere along the urinary system. So catheterization or instrumentation, calculi will cause white cells. We sometimes see it with transplant rejection. Neoplasia is important to be aware of. Obviously interstitial nephritis, papillary necrosis, and then with some forms of kidney disease such as GNs and PKD, we will also see white cells in the urine. So white cell casts, as we see here, so we have a cast here with a large number of cells within it. And as I showed you in the initial diagram of the renal tubule, this is suggestive of intrarenal inflammation and is typically associated with interstitial inflammation. We can see it with many types of GNs, and we always think about interstitial nephritis and pyelonephritis when we see white cell casts in the urine. Okay, so to talk about a case. This is a 48-year-old female with a history of type 2 diabetes, latent TB, hiatus hernia, and hypertension. She's referred to the renal clinic by her primary for assessment of a rising creatinine, which over the past 9 months has gone from 0.8 to 2 milligrams per deciliter, and she feels perfectly well. She's taking metformin, metoprolol, lisinopril, and aspirin. In terms of her labs, her A1C is 7.8%, and her albumin to creatinine ratio is 220 milligrams. On her UA, she has trace protein, 1 plus blood and 1 plus leuks. And on her sediment, you see 10 red cells per high-powered field, 35 white cells per high-powered field, and no casts. In evaluating this patient, which of the following is correct? Urine eosinophils have a high specificity for interstitial nephritis. Renal TB is very unlikely in the absence of fever. Progressive diabetic nephropathy could explain her explanation. The presence of red cells in the urine does not exclude interstitial nephritis, and the presence of 1 cyst in each kidney suggests possible PKD. So I'll give you guys a chance to answer that. Okay, all right, we'll stop there. And so most of you think that the correct answer is D, the presence of urine red cells does not exclude interstitial nephritis. Okay. And I agree. So for this particular case, we'll talk about the urinary eosinophils in a minute. As most of you are aware, obviously, renal TB does not necessarily present with fever and with the typical symptoms of tuberculosis that we see. This is unlikely to be diabetic nephropathy because her creatinine is rising a lot faster than one would expect for her degree of albuminuria, and at her age, she's allowed to have a couple of cysts, so not necessarily diagnostic of PKD. So we would be concerned about interstitial nephritis in this particular case. So to talk a little bit about acute interstitial nephritis and what are the drugs that are involved. So this is a paper from KI from 2015 where they looked at older patients and found that they had significantly more drug-induced rather than idiopathic or autoimmune interstitial nephritis, and that PPI-induced interstitial nephritis was very common. So 87% of cases of interstitial nephritis were drug-induced, and of those, 18% were secondary to PPIs. And compared with the younger population, where about a little over a quarter of them were autoimmune, this was much less likely in older patients. And those that had drug-induced interstitial nephritis had a higher prevalence of baseline CKD, developed higher peak creatinine, and had more need for dialysis. The commonest culprits were what we generally see, penicillins and also omeprazole, and 86% of them had a partial or complete recovery by 6 months. But one of the issues was the PPI-induced interstitial nephritis. These patients had a longer duration of exposure to the drug, but they had less severe AKI and tended to have good recovery by 6 months. So this was in this particular study. And then there was this large study from JAMA Internal Medicine in 2016, which is a population-based study looking at the risk of chronic kidney disease related to proton pump inhibitor use. And this is, I think, quite a live topic at the moment that's being investigated. So these investigators used the URIC study population, and they looked at 10,500 patients and made a correlation between their PPI use and the development of chronic kidney disease. And they found that those patients that used PPIs had a hazard of 1.5 for the development of CKD, had a hazard of 1.64 for developing AKI. So significantly increased risks when they had tried to control in this population for a large number of other variables. They then replicated this data in a cohort of almost 250,000 patients who did not have baseline CKD, and these were from the Geisinger Health System. The correlation was not quite as strong, but still persisted. So they found that there was a hazard of 1.17 for the development of CKD in these baseline healthy people, and that their 10-year risk to develop chronic kidney disease was 1.7%, with a number needed to harm of 59, which is quite low for drugs that are so widely used and freely available over the counter. So I think this is something that we need to think about in caring for our patients, many of whom do take PPIs that we may not be aware of. So other causes of drug-induced interstitial nephritis, I could spend all the rest of the time just listing medications that have been linked with this, but the common ones we see obviously are non-steroidals, cephalosporins, diuretics, loop diuretics in particular are important. Ciprofloxacin, cimetidine, and allopurinol are common. And then what leads to poor outcomes in these patients is when they have a longer exposure in therapy, in taking the culprit agent. And there also does appear to be a correlation between a delay in initiating steroid therapy in terms of poor outcomes. So those that start steroids earlier tend to do better. So urinary eosinophils in the diagnosis of interstitial nephritis. And I'm not sure how it is in all of your hospitals, but certainly the residents love to send urine EOs at the Brigham, and we get very excited phone calls pretty regularly that the urine EOs are high, therefore this must be interstitial nephritis. So I always try to send them to this paper to think about it a little bit more. So in this study, they looked at 556 patients who had a kidney biopsy and urine eosinophils sent. And of those, 82% of them had pyuria. 133 of the biopsies showed interstitial nephritis, and of those, 80% were drug-induced. So this was a good population with a lot of data in it. If they used a 1% urine EOS cutoff as diagnostic for AIN, it had a 30.8% sensitivity and a 68% specificity, with a positive predictive value of 15% and a negative predictive value of 84%. So pretty poor. If they used a 5% urine EO cutoff, which was a bit more stringent, the sensitivity was even lower, but the specificity was somewhat better. They tried different things. They tried just looking at patients who had pyuria, which would make sense, and those had somewhat better sensitivity, but again, a fall in specificity. And for me, this is probably the most important graph in the table, because in the paper, because it looks at urine eos and other forms of kidney disease. And essentially, even if you use a 5% cutoff in urine eos, which is the dark part of the bars here, so 5%, this is interstitial nephritis here. So if you use less than 1% urine eos, 1 to 5% or greater than 5%, this is the number that were detected. But as you can see, if you look at ATN, there's a reasonable amount of your patients that will have high urine eos here. This is crescentic GN. They have a lot of white cells in their urine. Obviously, some of them will be eosinophils, and proliferative GN. So really, using urine eosinophils in any form of kidney disease where you have inflammation and white cells within the kidney, it doesn't distinguish well between one form or the other. So it certainly is not diagnostic of interstitial nephritis. So moving on to hematuria. So how do we diagnose hematuria? So first of all, the dipstick, you need to remember, can be positive in the presence of red cells, hemoglobin or myoglobin. So to diagnose hematuria, you need to have more than 2 red cells per high-powered field. And how prevalent this is in the population very much varies with who's studied. So it's thought to be anywhere between 0.2% and 16% of the population has intermittent dipstick or microscopic hematuria. So as I mentioned earlier on, from a diagnostic point of view, when you want to think about hematuria and glomerular disease, what you're particularly interested in are the presence of acanthocytes in the urine. Other forms of dysmorphic red cells have quite a poor predictive value in terms of diagnosing glomerular bleeding, but these particular type of acanthocytes with the membrane blebbing, when there is more than 5% of them seen on phase contrast, this does have quite a high specificity of 98% and a sensitivity of about 50% for the presence of glomerular bleeding. So this is a very useful finding. So what are the false positives for hematuria? This may be relevant to the boards. So in true hematuria, your spun urine, the supernatant will be clear and the pellet will be red because all the red cells will have fallen to the bottom. If you have a red supernatant where the dipstick was positive, this suggests that your red cells are lysed, which can happen in a very dilute urine, and you've got either myoglobin or hemoglobin in the urine. If you have a red supernatant, so if the urine is red colored but the dipstick is negative, that's something other than blood in the urine, and that's something that can be seen in porphyria, AIP, hereditary coproporphyria, and variegate porphyria. You'll see it with beet ingestion or with phenazopyridine. It's one of those trick questions that comes up every now and then. So what do we do when we see patients with hematuria? So first of all, it's important to confirm the presence and confirm it on microscopy. So all patients should have urine microscopy to be sure that they actually have more than 2 red cells per high-powered field. And the American Urological Association guidelines are that all patients should have CT urography, and I'll talk about this a little bit more because there was another paper published last month that looked at the risk-benefit of this. Cystoscopy is recommended for anyone with persistent hematuria, particularly if they're over 40 or have risk factors for urothelial malignancy. And then urine cytology is cheap and risk-free. It has a very good sensitivity for bladder cancer, but is not particularly good for upper tract tumors. So when we think about isolated hematuria, and really I'm talking about microscopic hematuria for the most part here. So the glomerular causes are generally IgA nephropathy, thin basement membranes, or the familial nephropathies. And then the non-glomerular causes, there's quite a long list, obviously trauma, urologic malignancy, nephrolithiasis, cysts, papillary necrosis, certain metabolic abnormalities in the urine, like a lot of calcium or uricosuriya, infection, or any kind of inflammation can give you isolated hematuria. The rarer causes we should think about are sickle cell disease, if there are AV malformations or fistulas, particularly in patients who are post-kidney biopsy. This can be important to think of. Renal TB or schistosomiasis will also give you hematuria. So in considering urologic evaluation, I think it's useful to risk stratify patients. So those that are over 45, about 20% of them will have an abnormality on urologic workup, and about half of those will have a malignancy. Those that are under 45 are much less likely to have significant urologic abnormality. And I think the degree to which you investigate them should be considered, this information should be considered when you're deciding how much you're going to investigate them. What are the risk factors for urologic malignancy? So being over 40, smoking history is important. Rubber industry workers or those that have exposure to occupational dyes. Patients that have a history of gross hematuria or chronic cystitis are at risk of urothelial malignancies. Those that have had pelvic irradiation, and our patients who have cyclophosphamide. I think when we're taking care of patients who have lupus and who have ANCA and who have maybe chronic hematuria, even though their disease has been well treated and they've had cyclophosphamide in the past, it's important to keep a fairly low index of suspicion and a low threshold to send those patients to urology for cystoscopy because they can have chronic hematuria and you don't want to miss them developing a bladder cancer from their cyclophosphamide exposure. Those that have a history of analgesic abuse and have papillary necrosis are at risk for urologic malignancies, and anyone that has a chronic indwelling foreign body like stents or suprapubic catheters also are at risk. So this is the schema that's been proposed by the American Urologic Association, and we start off. Where am I there? So so you start obviously with history and physical exam. If the repeat UA is negative, or if you've treated the infection and it's gone, obviously no follow-up. If the microscopic hematuria remains present, they suggest renal function testing, cystoscopy, and CT urogram. If patients can't have a CT urogram, they talk about checking MRI. If they have proteinuria, you send them to a nephrologist for workup. If you find something, you treat it and make sure that it's resolved. And if the workup is negative, they suggest that you follow up annually for a couple of years and maybe consider repeat workup again within 3 to 5 years. If it's persistent and if it resolves, you release from care. This particular panel here in terms of the imaging, so there was a study that was just published a couple of weeks ago in, I think it was JAMA Internal Medicine, where they compared the American Urologic Association guidelines with some guidelines from the Netherlands, Canada, and then what's done in the Kaiser Permanente system to assess for microscopic hematuria. And the focus of the study was to use a machine learning algorithm to predict the number of cancers that would be detected and adverse events that might occur in different types of screening. And they calculated their rates based on per 100,000 population. And for the Canadian and the Dutch criteria, what they do is they do renal function testing, they do cystoscopy, and they do ultrasound. And for the Kaiser Permanente guidelines, I think they had a more nuanced approach where patients were recommended for CT based on their risk factors, older age, and certainly those that had a history of frank hematuria were recommended to have CT, but not such a blanket recommendation as those in the AUA guidelines. And what I found quite interesting about the study was that the AUA guidelines had the highest rates of detection of urothelial malignancy, as you would expect. I think they predicted about 97% detection, but the Canadian and Dutch approach detected maybe 93, 95%, so not that many fewer bladder cancers and urothelial cancers. But the caveat was that the cost per detection of cancer in this particular structure was was much, much higher. So this was a much more expensive way to detect cancer, exposing a lot more patients to radiation, and there was a predicted risk of radiation-associated secondary cancers that was much higher by CT scanning everyone rather than trying to think about risk stratifying and maybe using ultrasound as a first step. So I think, that was kind of food for thought when I was going through this talk again. And I don't think that, the AUA have not updated their guidelines or anything like that. I think for yourselves in your own clinical practice, it's important to know that things are done differently in different health systems. It doesn't necessarily appear that the outcomes are an awful lot worse as long as people are careful and thoughtful and follow up on abnormalities, and that potentially CT scanning everyone may not be entirely necessary and may carry some risk in terms of cost and radiation exposure. So what is recommended for the long-term follow-up of those that have persistent hematuria and have gone through an algorithm and where you've not detected anything? What happens to them? So if you follow them for a number of years, about 5% of them will find something within 3 years. So really not too many, and only about 1% are subsequently diagnosed with urinary tract malignancies. So the recommendation of how frequently they should be screened, how aggressively they should be screened and followed, that's really not well known. For this particular study, they suggested following up at 1 year, maybe with a repeat ultrasound and cystoscopy. But again, I think you need to consider from patient to patient as to what you think their basic risk factor profile is. So to move back to the kidneys, so what are the causes of isolated microscopic hematuria from a glomerular disease? This was a study from the 90s where they looked at 165 patients who were biopsied for isolated microscopic hematuria. So they had normal renal function, no proteinuria, and were normotensive. So almost 30% of them had IgA. About 4.5% had thin basement membranes, and then they had a range of other things, including MPGN, focal proliferative GN, and membranous on a small number then, which is surprising in the absence of proteinuria. And about 7% of these patients were young. They had a mean age of 37 years, had an abnormal cystoscopy. So again, emphasizing that most of these young patients will have something renal as the cause of their hematuria. And what happens to them when you follow them up? This is a follow-up study of 49 patients who underwent biopsy, and they were found they had hematuria for more than 6 months with an otherwise negative workup. About 18 out of 49 of them had macroscopic, but the majority had microscopic hematuria. And at 11-year follow-up, of those that had IgA, only 5 out of 12 developed hypertension. It was seen in about half of the patients that thin basement membranes, and most of the patients that had some other diagnosis on their biopsy. And similarly, increase in proteinuria in about 4 out of 12 of the patients with IgA, about half of the patients with thin basement membrane, and very few of those who were normal. So the take-home message I would take from this is that if you have patients who have isolated microscopic hematuria and nothing else, by 10 years, there's kind of a 50-50 chance that they'll have hypertension and proteinuria, and it's worth following them for that. It would appear that none of these patients had anything on biopsy that led to a change in their treatment initially, which is often the criteria that we use when we're considering whether to biopsy these patients or not. This is a study that I always refer to because I find it quite striking. This was from Israel, where they looked at 1.2 million candidates for the Israeli army who were 60% male between the ages of 16 and 25, and they underwent their screening medical. And they selected those candidates that had dipstick hematuria confirmed by microscopy. All of the patients included in the study had assessment by nephrology and had no other abnormalities apart from isolated microscopic hematuria. And at 20-year follow-up, and remember that these are age 16 to 25, a 20-year follow-up, they had a very large increase in their risk of end-stage kidney disease. So 34 versus 2 per 100,000 patient years with a hazard ratio of 18. So this is quite striking. And this was mainly due to glomerular disease. So hazard of 32 for end-stage kidney disease from glomerular disease in these 16 to 25-year-olds with nothing except isolated hematuria. So I think this does, again, emphasize that it is worth keeping an eye on these patients because some of them will not necessarily do as well as we would like. Okay, so let's go through a couple of cases. So we have a 35-year-old male who comes to review after a dipstick hematuria was found on an insurance medical. He's a non-smoker with no hypertension, renal impairment, or proteinuria. You CT'd him and it's negative. He has no family history of note. He has a grandmother with a hearing aid. So his urine sediment analysis shows 8 to 10 non-dysmorphic red cells per high-powered field with no casts. So the most likely underlying abnormality here is a defect in the gene encoding the alpha-5 chain of type 4 collagen, a defect in the gene encoding the alpha-3 chain of type 4 collagen, a defect encoding PC1, a defect in the UMOD gene, or a defect in the gene encoding the alpha-1 chain of type 3 collagen. And given that Dr. Renke has gone through this, it should help. Okay, so most of you, we have a little bit of debate between A and B, but most of you are coming down on B, which is a defect in the alpha-3 chain of type 4 collagen. Okay, and I agree with that. So let's go through what we think here. So PC1, as you know, is a mutation in the PKD1 gene, which is the commonest cause of ADPKD. UMOD gene encodes TAM horseful protein, and this is abnormalities here are seen in medullary cystic kidney disease. Type 3 collagen is Ehlers-Danlos syndrome, so not really relevant to us. And then X-linked Alport syndrome is a defect in the alpha-5 chain. So that's unlikely in this particular patient because he has no family history of end-stage kidney disease or deafness, whereas thin basement membrane diseases where you have a defect in the alpha-3 chain of type 4 collagen, and most likely in this particular case. So to talk about thin basement membrane, and the classification of this has changed a little in recent years, and this now is considered within the family of Alport nephropathies, whereas a number of years ago we always thought this about a very benign condition. Based on biopsies of transplanted kidneys, it's estimated that the population prevalence is about 5 to 9%, whereas it's clinically seen in less than 1%. About half of them will have a family history of hematuria, and it's often in a dominant pattern within the family. And they generally have no family history of hearing or visual impairment or frequently kidney disease. So the mutations are in the genes encoding alpha-3 and alpha-4 chains of type 4 collagen, and this is a carrier state for recessive Alport. So they've got one of the two, so one copy of the abnormal gene. Patients, it's generally picked up on microscopic examination, just on a routine UA, usually completely asymptomatic, but occasionally you will see a patient who has frank hematuria, loin pain, or AKI secondary to very heavy hematuria. It is a biopsy diagnosis where the harmonic mean of the glomerular basement membrane is between 150 to 225 nanomicrons versus 3 to 400 normal. And the prognosis is generally considered to be excellent, but there is some association with the development of proteinuria and secondary FSGS and chronic kidney disease, as Dr. Renke alluded to earlier. Alport syndrome is where you have mutations in the genes for type 4 collagen affecting alpha-3, 4, and 5. And these collagen chains are within the glomerular basement membrane, the cochlea, and the eye, which explains the clinical presentation. 80% of the cases are X-linked inheritance, so they're mother to son for the general presentations, and these are mutations in the COL4A5 gene, which encodes the alpha-5 chain. You can see some involvement in females occasionally because of the effects of lionization, but generally this tends to be very mild. 15% of Alports will be autosomal recessive types, and these are mutations in the COL4 A3 and A4 genes, and then 5% of Alport are an autosomal dominant type, which are also abnormalities affecting the alpha-3 and alpha-4 chains, but this dominant type is a much more, a less rapidly progressive clinical phenotype than the recessive or the X-linked. So up to 15% will have no family history. Patients will present with macroscopic hematuria and can be temporarily linked with respiratory tract infections in childhood. They tend to have progressive chronic kidney disease and proteinuria, and the progression of their sensory neural hearing loss tends to follow the same pattern as the progression of their chronic kidney disease. And these patients with X-linked forms and recessive forms tend to reach end-stage kidney disease about by the age of 30, whereas those with the dominant form of Alport, it occurs a little later in life. So you've already seen this with Dr. Renke, where you see the normal glomerular basement membrane here. This is thin basement membranes, where you can see it's uniform and but quite significantly thinner than the normal, where in Alport syndrome you have this very abnormal split laminated with this basket weave type appearance in the glomerular basement membrane. If you do immunostaining, you will see a lack of the particular chain, collagen chain that is involved for that particular subtype of Alport. And for some of them, you may be able to detect the absence of the alpha-5 chain on skin biopsy. So for treatment, there isn't anything specific. Unfortunately, ACE inhibitors have been shown to delay progression in those that have proteinuria. There is some conflicting data around the use of cyclosporin as an antiproteinuric agent, but obviously for those with progressive chronic kidney disease, you need to be a little careful in this. The one caveat that I would add here, when you're taking care of these patients, they tend to do very well post-renal transplant. However, you have to remember that there is a neoantigen in the glomerular basement membrane. So these patients have not previously been exposed to the alpha 3, 4, or 5 collagen that is abnormal to them, and they do have a 3% incidence of anti-GBM disease post-renal transplant. And two things to remember about this. First of all, the serologies may be negative because the antibody is not necessarily against the good pasture antigen. So having a negative anti-GBM antibody does not exclude this condition post-renal transplant. It's a biopsy diagnosis where you'll see the linear staining similar to what you would see in regular good pastures disease. And the second thing to remember is that the clinical phenotype actually is a little different, and these patients tend not to do quite as badly as they do with good pastures. Okay, we're running a little short on time, but let's see how much I get through. So next case, we have a 29-year-old female who's referred for assessment of recurrent episodes of frank hematuria and left-sided flank pain. Her exam is normal. She has normal renal function, normal imaging, and she undergoes cystoscopy, and blood is seen coming from the left ureteric orifice. So what is the most likely diagnosis? Does she have thin basement membranes, transitional cell CA of the left ureter? Could this be nutcracker syndrome, renal calculi, or IgA nephropathy? Okay, so we have a range of opinions here. So some think this is thin basement membrane, some think that she could have a transitional cell CA, and some are concerned about nutcracker syndrome. Okay. So the most likely diagnosis here is the nutcracker syndrome. So because it's unilateral bleeding, it's unlikely to be IgA or thin basement membranes, which would affect both kidneys. She's very young, so she's less likely to have a urothelial abnormality. The history isn't suggestive of stones, and you didn't see any on imaging. So by diagnosis of exclusion, essentially, I would say it's nutcracker syndrome. So what is this? So this essentially is an anatomical abnormality where the insertion of the superior mesenteric artery into the aorta is at a more acute angle than is normal. Because you have a more acute angle in the insertion here, the left renal vein is compressed. If the left renal vein is compressed, you get venous hypertension within the kidney and hematuria as a result. Patients can also have dilation of the testicular or ovarian vein on that side, and this can sometimes also give symptoms. So it's commoner in women than in men, usually seen in the 3rd to 4th decade, and patients usually present with frank hematuria, but they can also present with loin pain. Men can present with a left-sided varicocele, and women can have pelvic congestion with dysmenorrhea or dyspareunia. The diagnosis, you'll see this left-sided ureteric bleeding on cysto. On the Doppler, you may see an abnormality, or on the CT MR venography, but the gold standard is checking the gradient across that left renal vein, where you'll see an increased gradient there. For the most part, it's symptomatic management, and the vast majority of patients don't require intervention. But for those who have severe symptoms or hematuria to the degree that they require transfusion, there is a few reports in the surgical literature about doing reimplantation or even endovascular stenting to try to relieve this syndrome. We'll go through one or two more cases. So the 78-year-old male is admitted following presentation with dyspnea, increased edema, and found to have AKI. He was diagnosed with AFib and started on warfarin a month ago. A week ago, his INR was 4.8 and they reduced his dose, and today his INR is 1.5. He reports that his urine is dark and has decreased in volume over the last 3 days. His creatinine today is 3.5, increased from 1.7 a month ago, and his urine shows a lot of non-dysmorphic red cells but no casts. Which of the following is correct regarding his presentation? His clinical presentation may relate to the treatment of his AFib. His prognosis for renal recovery is excellent. His presentation is suggestive of a type 1 cardiorenal syndrome, or C3 complement would be increased in this condition. So I'll give you just a couple of seconds because we're a bit short on time. Okay. And so most of you think that this relates to the treatment for his atrial fibrillation. Okay, great. And I also agree with you. So the main differential diagnoses here are what's called warfarin or anticoagulant-related nephropathy, or you would also worry about renal atheroemboli in somebody who's got newly started on anticoagulation and has got AKI. So for either condition, the prognosis for his renal recovery is pretty poor, and we'll talk about this briefly. This is not in keeping with type 1 CRS, and if this was atheroemboli, we might see a decreased complement C3, but complement doesn't change in warfarin-related nephropathy, so D is incorrect. So what is warfarin-related nephropathy? This was one of the initial studies looking at it back in 2009, where they described 9 patients who had unexplained acute kidney injury on warfarin therapy and who had been biopsied. And they identified occlusive red cell casts within the nephron. They found red cells within Bowman space, and on EM they saw dysmorphic red cells in the tubules. All of the patients had underlying chronic kidney disease, and of the 9 patients that were identified with this condition, they had a pretty poor prognosis. 6 of them failed to recover, so had progression of their chronic kidney disease, and 4 remained on dialysis. The same group did a follow-on epidemiologic study where they looked at unexplained acute kidney injury within 1 week of having an INR over 3 in warfarinized patients without evidence of hemorrhage. And so this is being reported in the literature, and really the true incidence is unknown because most of us tend not to biopsy these patients frequently because you can't stop the anticoagulation. But it is estimated to occur in up to 20% of patients with chronic kidney disease where they initiate anticoagulation, that they develop a subsequent AKI. The risk is highest within the first 8 weeks of initiating, and it's generally seen when they're over anticoagulated, so with an INR over 4. It has been associated with accelerated progression of chronic kidney disease, and there was an observational study that reported up to 30% mortality within 1 month of diagnosis. Difficult to correlate because there are obviously many reasons, and they may be confounding my indication with initiation of anticoagulation, but certainly this is a poor prognostic sign when you see it. And this has also been reported with the DOACs, not just with warfarin, so this is something to keep an eye out for.